Brain Aging and Ayurveda. Contents. Chapter 1 Introduction. Chapter 2 Biology and Overview of Aging, an Ayurvedic Concept. Chapter 3 Motor Concept of Aging. Chapter 4 Age-related neurochemical changes and their regulation by Ayurveda formulations. Chapter 5 Antioxidant property of hippophy rhamnoids and its role in the management of neurodegenerative disorders. Chapter 6 Age-consistent hyperhomocystinemia and risk of neurodegeneration benefits of hippophy rhamnoids. Chapter 7 Heavy metal-induced neurotoxicity and amelioration through hippophy rhamnoids, C. Buckthorn. Chapter 8 Neurodegeneration associated with cardiovascular disorder and role of Ayurvedic management. Chapter 9 Ayurvedic modalities for management for senile dementia of Alzheimer's type, SDAT. Chapter 10 Prevention and management of Parkinson's disease by Ayurvedic formulations Baller. Chapter 11 Role of Ayurvedic formulation in the management of anxiety neurosis among elderly. Chapter 12 Role of Ayurvedic formulation in the management of depression among the elderly. Chapter 13 Management of insomnia among the elderly by Ayurvedic drugs. Chapter 1 Introduction. In the society, everyone over age of 65 is designated as elderly, whereas some of the authorities consider the field of geriatrics to keep this age over 75 years. With advancing age, multiple diseases and nutritional problems are the variety of reasons involved with elderly people. The functional capacity of most of the major organ systems show a decline, beginning in young adulthood and continuing throughout life. Among the elderly population, the dependency due to physical and mental disabilities is the major factors responsible for adverse quality of life and health care. Dementia, delirium, anxiety, depression including various cardiovascular functions rapidly deteriorates due to aging process, with the result, elderly population extensively use medical and personal care services. Recent advancement in the field of medical research in the last few decades, the life expectancy has tremendously increased. More people will suffer from a variety of age-related neurodegenerative and cardiovascular disorders worldwide. Neurodegenerative disorders are diseases of nervous system, including the brain, spinal cord, and peripheral nerves, that have many different etiologies. Some of them are hereditary. Some others are secondary to toxic or metabolic process. Two broad mechanisms are involved in neurodegenerative diseases: oxidative stress and excess activation of glutamate receptors. Genetic, environmental and vascular disorders are predominantly involved in the pathogenesis of neurodegenerative disorders. Genetic defect, abnormalities of antioxidant enzymes, autoimmunity, mineral deficiencies, metabolic toxicity, hypertension and other vascular disorders are the risk factors involved in neurodegeneration. The nutritional deficiencies, particularly vitamin B6, B12 and folic acid, lead to hyperhomocystinemia, which is also a leading cause for dementia. Environmental toxins, vitamin deficiencies and aging process can alter cognition. The morbidity and mortality due to Alzheimer's disease, AD, Parkinson's disease, PD, and stroke has increased and requires more financial involvement. A number of changes take place in the brain during aging at molecular, cellular, structural and functional level. Neural cells may succumb to neurodegeneration resulting in AD and PD. Recently, stem cell biology is emerging as one of the specialty areas in the field of neurosciences, particularly ongoing. Research suggests that any type of cells in the body, including neurons loss, can be replaced. Each neurodegenerative disorder is characterized by dysfunction and degeneration of specific neurons, particularly involved in learning and memory process, such as hippocampus and cerebral cortex are affected in Alzheimer's disease, resulting in motor dysfunction. Memory loss, language impairment and poor attention power that impair the ability to perform activities of daily living strongly suggest neurodegenerative dementia. Age-associated neurological impairment causes memory loss and senile dementia. It can occur at any age but become more frequent with advancing age. It is seen more frequently in women due to increased longevity. Dementia involves nerve cell deterioration, defined as a loss of complex behavior, including language, memory, visual and spatial abilities. Dementia, the most serious form of age-associated mental impairment, is often a slow and gradual process that may take months or even years to become noticeable. Dementia is described as involving multiple and progressive cognitive decline in older persons in the absence of disturbances of consciousness. Family members who observe closely can accurately identify patients with dementia and memory loss and can assess their degree of physical and functional health. Cognitive decline occurs in a cluster of symptoms can be divided in three categories: mild, moderate and severe. In mild dementia, short-term memory is impaired, especially word-finding. Aphasia, anemia and apraxia can develop. Executive function is impaired. Apathy is common. Emotional lability is also common in elderly people with mild cognitive impairment. Elderly people who do not perform simple daily activity like bathing, dressing and toileting come under moderate dementia category. In this category, patients cannot learn new information. In severe dementia, patients cannot perform the most basic activities like eating, walking and become totally dependent on other people. Memory for recent and remote events is completely lost and patients are not able to recognize even the family members. Ability to swallow is lost and at the end stage dementia may result in coma and death. Neurotransmitters such as glutamate, acetylcholine and dopamine play an important role in the regulation of neuronal circuit and influence the neurodegenerative process. Similarly, estrogen and testosterone, glucocorticoids also influence brain dysfunction and structure during aging process. Glutamate and GABA, the major excitatory and inhibitory neurotransmitters, are responsible for the protection of neuronal survival and synaptic plasticity. Overactivation of glutamate receptors causes neuronal death, particularly under condition of increased oxidative and metabolic stress, which occurs in age-related neurodegenerative disorders. A significant disruption in serotonergic neurotransmission is noted in dementia. The serotonergic neurons innervate many structures in the cortex and limbic system and regulate aggression, mood, feeding, sleep, temperature, sexual activity and motor activity. It has been postulated that neurotransmitters are altered in dementia and each has a definite role in the regulation of human behavior. 5-HTA receptor is involved with anxiety, depression, aggression and appetite. Decreased 5-HT receptors were found in people with age-related memory disorders or dementia. Loss of cholinergic neurons is an early and consistent finding in AD. There is a massive change in cholinergic system in AD, including deficits in cholinergic system. Decrease in cholinergic markers choline acetyltransferase, CHAT, and acetylcholinesterase, ACE, in the cortex, loss of neurons in nucleus basalis of Maynard and also reduction in muscarinic type 2 presynaptic receptor density are estimated in various types of dementia. Both serotonergic and noradrenergic system interacts in many ways. The serotonergic system inhibits the release of noradrenaline via 5-HT receptors, thus, the loss of adrenaline neurons is correlated with severity of dementia. Similarly, the serotonergic neurons interact closely with dopaminergic neurons via 5-HT receptors. Serotonergic neurons either inhibit or increase the release of dopamine. Thus, the loss of serotonergic neurons will affect the dopamine system. This system has a major role to influence dementia directly. GABA is the primary inhibitory neurotransmitter in the CNS. The presence or absence of GABAergic abnormality is significantly associated with behavioral changes in AD. In AD patients, the biochemical defects are responsible for a number of changes. There is a marked decrease in choline acetyltransferase and other markers of cholinergic neuron activity. Decrease in brain dopamine, norepinephrine, serotonin and somatostatin concentrations have been reported in Alzheimer's disease. Such patients are sensitive to CNS toxicities of drugs with antimuscarinic effects. Many methods of treatment of AD have been explored, but there is no convincing evidence of their efficacy. Anxiety and depression is common with aging and is one of the causes of memory impairment in elderly people. It is estimated that isolation and physical disability influence the high incidence of depression among the aged. Depression not only hampers the quality of life but also causes the memory impairment. Depressive illness is typically accompanied by overall lack of drive and motivation, loss of interest in routine activities, poor appetite, early fatigue, insomnia and loss of weight. Behavioral disorders have long been recognized as a common feature in dementia. The nature and frequency of the behavioral and physiological symptoms have been established in various studies. Behavioral and psychological symptoms of dementia can include psychotic symptoms such as hallucinations and delusional ideation, non-psychotic symptoms such as aggression, wandering, affective disturbances, anxieties and phobias. Behavioral and physiological symptoms of dementia occur throughout the course of dementia and commonly associated with cognitive impairment. It is estimated that up to 90% dementia patients display behavioral and physiological symptoms of dementia. Recently, dementia is recognized as a complication of cardiovascular risk factors and termed as vascular dementia. The metabolic syndrome X has also been recognized as a risk factor of dementia, which includes hypertension, obesity, dyslipidemia and glucose intolerance, leads to an increased risk of diabetes and cardiovascular disease. All these factors have been associated with the increased risk of vascular dementia and Alzheimer's disease. The association between neurodegenerative disorders and abnormal lipids is gaining recognition. Lipids may influence neurodegeneration through direct effect on neurons or vessels, through atherosclerosis, or by chronic inflammation of the brain. HDL-C metabolism plays an important role in B-amyloid metabolism and deposition in the brain. Lower HDL-C and altered levels of ApoE1 are reported in demented subjects. ApoE is involved in the regenerative response of injuries to nerve tissue, and it is present in amyloid plaques of various amyloid-forming disease. ApoE is an important risk factor for AD and age-related memory disorders. Hyperglycemia has shown an adverse effect on hippocampus, memory area, and thus, increases the risk of Alzheimer's disease. The glycosylated end product B-amyloid is a protein produced in brain under influence of specific enzymes and increases the inflammation in the brain. Recently, it has been found that obesity in elderly increases the risk of dementia. The association of body mass index, BMI, to dementia is complex. It is noticed that women with high BMI index have a greater risk for dementia than men. Obesity and overweight in middle age, as determined by measurement of BMI and skin fold thickness of various body parts, were strongly associated with